Good morning, everyone. This is Jen Brockman from IHC. We're going to wait another minute or so and let people join us, and then we're going to go ahead and get started. All right, we're going to go ahead and get started. Again, this is Jen Brockman with the Iowa Healthcare Collaborative. Welcome to our December HIIN Learning Community. Just a few housekeeping items. Please put your phone on mute. We have all the lines muted, but just to keep all that background noise out, please keep your line muted. If you do have a question or a comment, please raise your hand in the chat box or type in your question into the chat box. We'll be monitoring the chat box throughout the presentations today. There will be 0.3 Iowa CEUs, nursing CEUs, that will be awarded for this webinar by the Iowa Board of Nursing. Iowa nursing CEUs will not be issued unless your Iowa license number was provided during registration. You must remain logged in to the webinar for the entire program, including breaks, to be eligible for nursing CEUs. The CEU certificate will be emailed to you within 2 to 3 weeks of the program through your registration email. Out-of-state nurses, if you're seeking CEUs, please provide your license number at registration. A certificate will be provided to you via email after the webinar, and then please contact your state Board of Nursing to verify the acceptance of those credits. Any questions regarding the CEU process, please contact Megan Wilshusen with the Iowa Healthcare Collaborative, and her email information is provided on our website and within the brochure as well. So we'll go ahead and get started with our first presentation today, which is me, and providing a HIIN update looking at moving into year 2. You know, we just finished year 1 of HIIN, and I think the hospitals have done an absolutely fantastic job of moving things along and seeing progress towards that 2012 target goal for CMS. So just a reminder for the Compass HIIN is made up of a partnership with the Iowa Healthcare Collaborative and the South Dakota Association of Healthcare Organizations. We have 153 hospitals in Iowa, South Dakota, and Illinois. And our network is comprised of approximately 80% of critical access and rural hospitals. HIIN-wide campaign results, if you recall, HIIN originally started back in 2011, and that initial project period was about 3 years. There was a short interim period, and then 1 year HIIN 2.0 time period that ended the end of 2016. HIIN-wide campaign results through 2015. There were a 21% reduction in healthcare-required conditions, where we went from 145 hacks per 1,000 discharges to 115 per 1,000 discharges in 2016. There were $28 billion in estimated associated cost savings and between 2010 and 2015, and then 125 lives saved during that time as well. History of the HIIN. Again, HIIN 1.0 started back in 2011. It was started in the CMS Innovation Center. That first HIIN 1.0 period was 3 years. It went to the end of 2014. And then we had that short interim time period between HIIN 1.0 and HIIN 2.0. HIIN 2.0 started in September of 2015 and ended in 2016. Now with HIIN, the Hospital Improvement Innovation Network, that has moved into CMS proper under the QIO umbrella. And this contract is planned for a 2-year base period with the 1-year option year, very similar to the way HIIN 1.0 was structured. And with HIIN, one thing that we are seeing across the board with all of the 16 HIINs across the U.S. are the very strong partnerships with our QINs and our QIOs. With HIIN, there are over 4,000 hospitals across the U.S. that are involved in this project, which is up from the approximately 3,700 that have participated in HIIN 1.0. So what is HIIN? HIIN is the Hospital Improvement Innovation Network, and it's very much a continuation of the Hospital Engagement Network that we had done in previous years. We're working to engage hospitals, providers, and communities to implement well-tested and measured best practices. We're committed to fostering a culture of safety and reducing harm. And again, HIINs are collaborating very closely with the QIN QIOs through education and engagement of acute care hospitals. So part of HIIN and something that the improvement advisors with the Compass HIIN have been working on throughout this last year is building that strong organizational foundation, really looking at moving the quality work away from just sitting on that quality director, hospital quality director's shoulders, and building those teams within hospitals to address this work. So who are the players on your HIIN team? This is something that when the improvement advisors go out and talk to hospitals, they're really hitting this hard, making sure that they're meeting with several people within your organization that may have a role in this improvement work. What resources should everyone have? So working from the top down, starting with that leadership support and the buy-in to get the resources that are necessary to do this work within your organization. How often should your HIIN team meet? The improvement advisors meet with, typically meet with the hospitals on a quarterly basis or around that amount of time. Typically within hospitals, how often should your HIIN team meet depends on your organizational needs. Some meet on a monthly basis, some meet on a quarterly basis. It depends on how far you are into your HIIN work and maybe what some of your focuses are. And then what should you be involved in with IHC? Any of the work that we do here, and we'll talk more about some of the resources that we have available a little bit later on in this presentation, but any of the resources that are available to hospitals through the HIIN work is available at no cost to hospitals. The different projects that we do, our communication platform within Innovation, all of our communities of practice, we really do want you, or at least some member of your organization, involved across all levels with the HIIN work that we're doing. So here's just a pretty basic list of the people that you should be including within your HIIN team. And this is not an all-inclusive list. This can include other folks, but definitely your quality department, a physician champion to help lead it from that provider level, infection preventionist, pharmacist, your health IT to help with building reports so you can pull data out of your EHR, PT, and definitely frontline staff. Your frontline staff are the folks that are leading this work at that unit level. So definitely having champions within your different units, different teams on different shifts is a must-do for the HIIN work. Like I had mentioned, the HIIN goals are 2012, 20% reduction in all-cause harm, and a 12% reduction in 30-day readmissions. For HIIN, the baseline year has been reset to 2014. If you recall, with HIIN 1.0 and HIIN 2.0, our baseline year was back in 2010. So CMS used the progress that we saw through HIIN 1.0 and HIIN 2.0 to reset the baseline, and therefore resetting our goals for HIIN. Core focus areas are very similar to the core focus areas that we had in 1.0 and 2.0. Additional focus areas, we are looking at the NDRO and antimicrobial stewardship. C. diff and sepsis have been moved into the core focus areas, which is a change from HIIN 2.0. And then obstetrical events has moved to an optional focus area. That has been moved out of the core focus area realm by CMS, but because of requests from hospitals to continue to collect and monitor that data, we have left that on as an optional area. So moving into Compass HIIN reporting, many of you know, if you've been doing this for a while, HIIN data sources are from basically three sources. The statewide database, which is submitted, hospitals from South Dakota and Iowa submit that data to the Iowa Hospital Association. National Safety Healthcare Network, or NHSN, which is submitted by the majority of our hospitals to NHSN. There are no requirements currently for critical access hospitals to report to NHSN, so it's purely voluntary. If you need assistance with getting enrolled in NHSN and getting that set up, please let us know and we're more than happy to help you. But the majority of our hospitals are have conferred rights to us and are submitting to NHSN. And then self-reported data through our Compass HIIN reporting database. A little bit more information about our reporting and our process. So the statewide database information that's reported to the Iowa Hospital Association is pulled on a monthly basis. So the Iowa Hospital Association pulls that data from the claims data from IPOP on or around the 20th of every month. Remember that hospitals, typically the deadline for reporting the self-reported data is 45 days at the end of 45 days after the end of the month. It's very similar for the claims data. There is no mandate to report claims data on a monthly basis, but in order to keep that real-time process improvement going and having that updated data available within the database, we do ask that all hospitals report your claims data on a monthly basis. Please be sure that you get in touch with your IPOP submitter there at your hospital. And if you have questions about who that might be, please let us know and we will get in contact, or you can contact Kathy Tritton at the Iowa Hospital Association and we will be sure to get that information for you. So the data is pulled on or around the 20th of every month. The HIIN database is then populated into the HIIN database, and the database is refreshed and that's right around the 1st of every month. And once that is refreshed, the run charts, goal reports, and dashboards will show those updates to your data. For NHSN data, very similar. Data is pulled on or around the 20th of every month. We pull that here from the hospitals that have conferred rights to us, so we do. We know that there are requirements for PPS hospitals for quarterly reporting, but nothing presently for monthly reporting to make sure that it's reported in that month's time. but we do ask that all hospitals report on a monthly basis, again, for their Nhsn data. Then on or around the first of every month, the HIIN database is refreshed, and then that data is available within the database. And then self-reported data. This is on demand. So once you report that data into the HIIN data collection tool or into the HIIN database, it is available on demand in those different reports that you can pull. Here are just some links, and these slides will all be available on Hinnovation. Some links to the Compass HIIN measure set if you would like some more information on the measure set. And then before the end of the year or right after the beginning of the year, after the new year, we're going to be sending out a new updated toolkit that will have some additional resources and information available within the toolkit as well. And then again, reporting for the HIIN database, there's a link there, and then the reporting your data worksheet for a little bit of information about the process we have internally. So a couple of reporting requirements. Hospitals are required to report on at least one process and at least one outcome measure for each focus area. The two exceptions are ADE and falls. For adverse drug events, again, we ask that all hospitals report the three high harm areas, which include anticoagulants, opioids, and glycemics. So we ask that all hospitals report the blood glucose less than 5, statin Narcan administration, and the blood glucose less than 50. For falls measures, we ask that all hospitals report all of the fall outcome measures. So this would include all your fall severity levels. Hospitals that do not provide a particular service, such as surgical care, ventilators, central line insertions, are excluded from the requirement to submit data for these focus areas. And that can be selected within the work plan to state that your hospital does not provide that service. So moving into progress. So this is looking at PFE, the PFE metrics, the PFE1, pre-admission planning checklist, PFE2, looking at shift change huddles or bedside reporting, PFE3, the designated PFE leader, PFE4, PFAC, or representative on a hospital committee, and PFE5, patient representative on a board of directors. And so the PFE AIR, our PFE contractor, recently released a updated roadmap for success, and the link is here. This is also available on Hinnovation as well. And it's really broken down nicely to include specific tactics for each one of those metrics for hospitals to use in order to accomplish the intention or the intent of each one of those metrics. So an update on our performance for HIIN PFE. If you recall, over the last couple months, improvement advisors have been reaching out to hospitals to really take a look at our PFE performance. We were contacted by CMS leadership earlier this summer, and there were some concerns about our lack of progress as a network, Compass HIIN, with our PFE. In HIIN 1.0 and 2.0, we were typically seen as a leader with our PFE efforts, and that kind of stalled out. And so we started to look into some of the issues that we might be having with PFE and try to determine, are we seeing underreporting or underperforming with regard to this work. And so improvement advisors started reaching out to hospitals individually, talking to them about the metrics, doing some re-education of the metrics, and really looking at determining where we were at with these. And I am very pleased to present to you the performance that we have, or the improvement that we've seen just over the last couple months. PFE1, we've gone from 57.5. So this is the number when you report to the Compass HIIN database, you can answer yes or no for each one of these metrics. And so this percentage is the number of hospitals that have answered yes to those metrics. So we've gone from 57.5% back in July to 71% in November for 1. PFE2, 58.4 to 80%, which is incredible. PFE3, 42% to 70%. PFE4, 38% to 58%. And this one is looking at PFACs, and we actually have Janet Lacey on a little bit later in the morning to talk about the work that they've done with their PFAC. And then PFE5, 38% to 65%. So I'm really, really, really happy with the progress we've seen across Iowa and South Dakota and Illinois, and fully expect to see continued progress over the next few months. And here's just a graphic illustration of the work that has happened over the last couple months, and you can see that really sharp uptick in the work that started about in August or September. So congratulations to all of you. I am really happy with the work that we have done here throughout the network. So moving into other progress. So these are looking at, you'll see 2 columns here, year 1 target and year 2 target. So when we first began HIIN, we had to set targets for our network and provide those to CMS. The overall target for each one of these is to hit that 20% for healthcare acquired conditions and that 12% for readmissions. So that's where we want to be by the end of year 2. For year 1 goes till the end of September. So we're still technically gathering data for year 1. So we're still kind of looking at what our year 1 actual is. But what we've included in this presentation here is data from October to July of 2017. And this is where we are currently. So you can look at the adverse drug events, those different categories, and you can see that for year 1, we have met or exceeded by far all of those year 1 targets, and most of those year 2 targets already just by July of 2017, with the exception of the statin naloxone usage. So this one, even though that 71% negative, this is below baseline, or this is, I'm sorry, above baseline where we want to be, we have seen consistent improvement over the last several months. And so I expect to see, with the work that was done with the hospitals that participated in the Opioid Guardianship Project, I expect to see continued results. And now with the Opioid Project that's coming up, starting in January, our Opioid Guardianship Take 2, I expect to see even more progress with this area. Hospital-acquired infections, again, for central lines, urinary tract infections, C. diff, and VAE, we have met or exceeded all of our year 1 targets. And with the exception of CAUTI and C. diff, we have met our year 2 targets already by the end of July 2017. I know preliminary data for C. diff, looking at where we are now, it's not as much progress as we would like to see. So there will be some additional work that we're doing with hospitals on C. diff throughout this next year. Surgical site infections, there's lots of colors on this slide, but so with hip and knee, we have not seen as much progress. We did not hit our targets for year 1. I can say that for colon, hysterectomy, hip, and knee, this all comes from Nhsn, and there are a very small number of hospitals that actually report this within Nhsn that we then report up to CMS. I can tell you that for a couple months here, when you look at that May to July performance, that negative 164, that was 2 hip infections, and 1 knee infection during that time frame. So because of our low N, the number of hospitals that are actually reporting those measures, 1 or 2 events can greatly throw off our improvement here. So I'm really not concerned about those. We'll continue to work on them and continue to work with hospitals on those. Again, for surgical site infections, if you have less than 10 of any of these types of surgeries, if you provide less than 10 of any of those, you are not required to report them to NHSN for HIIN purposes, but you are more than welcome to do so if you choose. And if you have questions about that or need some assistance with that, please let us know. Looking at falls, while we did not meet our year 1 target, we were well on our way to meeting that target. We were just shy of that so far as the end of July 2017. But I am still really excited and really proud of the work that hospitals have done with the falls, reduction in falls, because this is the first real improvement that we've seen in this area in the history of our work with HIIN and HIIN. So I think everybody should still be really proud of the work that they've done and the improvement that we've seen in this area. For pressure ulcers, we are typically a high performer in this area. Our rates are exceptionally low. And so for pressure ulcers, sepsis, and VTE, we have met or exceeded both year 1 and year 2 targets as of July 2017. So moving into optional measures, looking at MDRO, antibiotic timeouts, and antimicrobial agent days, we have met the year 1 target and are working towards the year 2 targets, so doing great with those. Back injury, needle stick, and safe patient handling. We did not meet the year 1 target so far for needle sticks, but have seen improvement in that area over the last several months. And then for abdomen and thorax CT, we have exceeded targets for those. And then readmissions, this is an area that we will be focusing on a lot, especially in this first 6 months of 2018 with the Readmissions Refuel project that's being led by Kate Carpenter. We have stuck right at or below baseline for readmissions, looking at readmissions to any hospital or same hospital. This has been pretty typical across all the HIINs and is a target area, a focus for CMS and all HIINs moving into year 2. Value estimates, this is another thing that we provide also within the dashboards on the HIIN dashboards within the database for each individual hospital. Looking at our year 1 actual, October to July, we have by far exceeded the goal for the estimated number of harms avoided. We have also exceeded the number of, the goal for the number of lives saved. And for our estimated cost savings, our goal was to hit a little over 29 million by the end of 2018, and we have exceeded that so far and are at over $35 million in cost savings just for our Compass HIIN hospitals. So congratulations to all of you. This last year has been fantastic. So resources available to Compass HIIN hospitals. We have the on-site assistance and or training that's available. We have our improvement advisors that are available to come on-site to provide frontline staff training to any of your departments. We have the Teach Back training, lean and process improvement assistance that's available with Sarah Pavelka, and team steps training that we have several master trainers on staff, and we are going to be doing a team steps series on innovation, so providing some more of those tools and information on team steps through innovation. Physician, pharmacy, and board engagement. We have faculty that is on staff and staff that is available to come out to provide some support and assistance to your providers, to your pharmacists, and your board for some leadership engagement. We have a great data team on staff that is able to help with some additional analytics. If there is something that you have questions on or would like a deeper dive into within your HIIN data, we have our data team that is able to provide that. Also, within the claims data, if IHC does not have access to patient-level data, but IHA does. So if you see something in your data and you would like some patient-level data for those claims-based measures, please let us know, and we can get in touch with Kathy Tritton at IHA to help pull that data and have them send that on to you. We have several improvement advisors that have assisted with community meetings, care transition support, helping with some of that, those collaborative care meetings to help set those up and get those rolling. We have lots of conferences and online learning opportunities. We have our monthly office hours call, which is the fourth Wednesday of every month. Our quarterly What's Up call, which will start up again the beginning of 2018, where we'll hear a little bit more about the national efforts from Dr. Evans. And then our monthly communities of practice, which we've done a pretty large restructure of our education for year 2. We heard from hospitals that they were feeling overwhelmed, getting hit with lots of different education and lots of webinars from not just IHC, but several different organizations, and they weren't able to participate in all of them. So to better meet your needs, we've scaled back our educational opportunities to really make them more intentional and make them more robust. And so rather than doing our typical monthly communities of practice, we will have 2 projects the beginning of 2018 that will run in 6-month cycles. And those 2 projects we will start off with are the Readmissions Refuel Project and the Opioid Guardianship Take 2 project. We will, however, continue the monthly HAI calls. The infection preventionists that were on those calls have said that they would like to continue with that community of practice on a monthly basis. The end of the year, we will look at 2 different projects, one around falls and one around antimicrobial stewardship, or CDIF. We're not sure what that one will look like yet. And then right now we're looking at some other educational opportunities throughout the year, potentially an antimicrobial stewardship workshop in the spring in collaboration with the Iowa Department of Public Health and the Iowa Hospital Association. We will still do our regional meetings, coming out to you guys and providing that regional data, the regional data workshops, the lean application series a little bit later this year in the summer. We had lots of hospitals really enjoy that this last year, so we'll plan on doing that again. And then our virtual learning communities and our 2 on-site learning communities that will be later this year. We also have Hinnovation that I encourage everybody to get signed up on. We are currently at right around 825 members on Hinnovation. It is a great place to ask questions, share successes, maybe talk about barriers. And it's not just Iowa hospitals, it's hospitals in South Dakota and Illinois as well. So it's a great network for you to reach out to for maybe mentorship opportunities, or just to pick some brains of other people that are in your situation. And then we have 2 publications that go out on a monthly basis. Our HIIN Huddle email that goes out around the 15th of every month. That is just a mid-month reminder of events that are coming up. And then our monthly drumbeat. And that is a little bit more inclusive, shares successes. We also share we choose a focus area and highlight our top 10 hospitals that are top 10 performers in a certain area. And so we want to see all of our hospitals on that top 10 list at some point or another. So continue to do that great work, and we'll be sure to highlight it. There's the link for Hinnovation. Like I said, please join the conversation. There's lots of stuff going on there. We have all of our events posted on there, all the event links, and it's a great one-stop shop for all of your needs. So I'm going to go ahead and open this up for questions. If you have questions, please type them in the chat box. I do have a couple questions here for slides. Yes, slides are available. They're available on Hinnovation. The link is available there within Hinnovation. And we will also post them again with the recorded webinar once it's transcribed, and that will be posted on Hinnovation as well. Other questions, comments, thoughts about anything in year one or moving on to year two? One question, will IHC be doing any educational programming on the opioid crisis? Yes, we will. So the beginning of this next year in January, we will be kicking off our opioid guardianship project, the second cohort. So information has gone out or will be going out this week. If you haven't received it yet, you should be. It will be posted on Hinnovation. It is going to be a 6-month-long project. So we took lessons learned from the first cohort and really did some enhancement of the opioid guardianship project for this next group. Actually, the informational call for the Opioid Guardianship Project is tomorrow. So that link is available on Hinnovation, and anybody is welcome to join. Any other questions? Questions about any of the data or any requests for this next year? All right. Well, we're running a little bit ahead of schedule here. We are going to go ahead and move on to our next presenter then. Randy Mcdonough is the co-owner of Towncrest and Towncrest Compounding Pharmacies in Iowa City and Salon Towncrest Pharmacy and Salon. He is a partner in Innovative Pharmacy Solutions, a consulting and clinical documentation software company. He helps foster collaborative working relationships with solo and group physician practices in immunizations, anticoagulation, disease state management, and medication therapy management services, and was instrumental in implementing MTM services for the Iowa Medicaid Pharmaceutical Case Management Program. Dr. Mcdonough received his degrees from University of Iowa College of Pharmacy, where he is an adjunct professor. So welcome, Randy. Let me pull up your slides here, one sec.
Jen, will you be taking care of the slides, or do I need to do it from my side?
Nope. I will take care of them for you. You just let me know when to move on.
I appreciate it. Well,
all right, so we'll go ahead and I'll hand it over to you, Randy.
All right, thanks, Jen. This is a presentation that I have done this last 6 months in quite a few different venues, talking about opioids, and in particular talking about some of the guidelines that the CDC came up with, which we'll address earlier in the slides, but also really focusing on the Pmp prescription monitoring plan and making sure that providers are utilizing that resource, that tool, so we can better assess our patients and just make sure we're identifying patients who might be at risk of abuse and helping them find the resources that they need if they are having problems with that. Want to go ahead and next slide. As Jen said, I'm Randy Mcdonough, and I'm actually a co-owner of several pharmacies. You heard, we do a lot of work, with the PMP, and we are a hospice pharmacy, so we deal a lot with narcotics and opioid use. So it always makes us wonder, sometimes we might be an easy target if people have found that out. We have had issues with people who have abused medications, and so we do utilize the PMP on a regular basis and communicate on a regular basis with the other providers so they know what's going on. Next slide, please. Really, the goals and objectives of this presentation is to review the CDC guidelines for appropriate prescribing of opioid medications, review proper record keeping for opioid prescribing, both from a prescriber perspective but also from a pharmacy and other providers' perspective as well, and then really discuss the benefits and challenges with the prescription monitoring plan. Next slide. We're going to put a little bit of focus now on just some of the statistics and data that's out there. Next slide. I think what's interesting as I look at this timeline and see some of the things that have changed over time, and I've seen this within my career in my 35th year as a pharmacist, so I've been through some of these time periods. And as I look at 1970, and I was just in early ages at that point, but in 1970 is when actually the Controlled Substance Act was passed. And the reason for that was to categorize medications based upon the potential for abuse. And then in 1971 is when Nixon actually had the war on drugs, and he stated that drug abuse was public enemy number one. And then in 1973, he created the DEA, the Drug Enforcement Agency, to oversee this aspect. In 1980, so I went to pharmacy school in 1982 and graduated in 1987. That's the first time when I got my bachelor's, went back and got my master's and my clinical doctorate. But back in the 80s, when we were taught in pharmacology and therapeutics, it's interesting because there seemed to be a fear about prescribing opioids. And what I was taught when I was taking courses in pharmacology with medical students is that we're doing a horrible job of treating patients' pain and that we need to do a better job of stepping up our treatment. So that was in the 1980s. In the 1990s then, it's still going on that we're saying we're having under treatment of pain. So there was a successful lobby for increased use of opioids. Physicians expanded treatment of pain with new opioids on the market. Opioids are being used to treat non-cancer pains. And there was a lot of marketing efforts by pharma to get providers to start using some of the new and improved and long-acting opioid products that were out there. Then we get to the 2000 to 2009, and now we start seeing some issues. So in 1996, the American Pain Society asked that pain be thought of as a fifth vital sign, and emphasized that pain assessment is just as important as assessment of the other four standard vital signs. Now we're starting to see the opioid prescribing increase. We're starting to see more misuse and abuse of the opioids. We're seeing a lot of increased use, quadrupled from 1999 to 2008. And now we're starting to see that research is being done to find abuse deterrent formulations for the medications. In 2016, multiple groups, including the AMA, came out saying we should scrap pain as the fifth vital sign just because of the potential of overprescribing opioids. Next slide, please. If you look at this slide, which I think is interesting, and really the top line, which is opioid analgesics, and this slide is actually representing illegal drug deaths. So these are drug poisoning deaths, and looking at the different products. So the bottom line, or the purple or the orange, is heroin. And we got the next one, blue, is cocaine, and the purple one is opioid analgesics. And these opioids are both prescriptions and illicit, and are the main drivers of drug overdose, as you can see. In 2015, opioids were involved in over 33,000 deaths. And as we mentioned previously, we've seen a quadrupling of the number of deaths since 1999. Next slide, please. as we look at this cycle and the opioid heroin cycle, what is thought has happens as far as patients who are now using heroin is a lot of them, and up to 90%, they would say that the people who are abusing heroin got started on opioid use, and typically a prescription medication. Then their use became more regular, and then unfortunately they start using it daily. Now they're starting to have withdrawal-like symptoms. That eventually leads to them seeking that they need the medication. So the transition from the opioid then to the heroin starts when the prescription runs out, they're not able to get the medications, and now they need this. And one of the things that I read once that made a lot of sense to me is they said once addiction is set in, it's no longer about getting high, it's about not getting sick. So then they go to heroin, it's readily available, it's a lot more potent than morphine. It can be given in a variety of ways. It could be snorted, injected, or smoked. Unfortunately, there's a lot of, obviously, other problems associated with the heroin use, including that it might be laced or replaced with something that might be even more potent, such as fentanyl, which is 100 times more stronger than morphine and 30 to 50 times stronger than heroin. And so obviously there's a concern that, there's going to be an increased number of deaths just because people are moving from the opioids to the heroin, and it's just a vicious cycle that way. I told you in our pharmacy, we see a variety of problems that we've come across. And one that really comes to my mind happened when we had a woman who came in asking for a pack of insulin syringes. We usually only are going to sell those, and usually it's not even a question. So that was an unusual request because it's our patients that normally would come in and get needles for insulin use. But she came in and she gave the story that she was picking up for her grandmother and that she was not able to get the prescription or get the needles from CVS. And we had called over to CVS and they just said that they didn't have what she was asking for, which I wasn't sure if that was a true response or not. So we were hesitant, but we ended up selling her a pack of 10 needles that she could use. Well, then she asked, and what was interesting about this story, she had a 5-year-old little girl with her as well too. She asked if she could use our restroom, and she went to the restroom, and it was a while that she was in there. When she came out, we could tell there was a definite change in her attitude, in her demeanor, and she just looked like she was high. Well, it ended up that she had cooked some heroin and had injected it when she was in the bathroom. And so when she came out, we noticed there's something wrong. I went in, I saw the burn marks on the top of the toilet, and so we ended up calling the police, and she ended up getting arrested, and we were concerned for the little girl. And I followed up the next day, and they said that they couldn't hold her in, and that the daughter got put back in the home with the parent. And so obviously this is affecting multiple patients. Multiple people are affected by this kind of abuse, but this is not uncommon to hear about this. And so it was an unusual event that happened to our pharmacy, but we've had employees steal from us with opioids. We've had people bringing in false prescriptions on a regular basis. So it behooves us to make sure we're on top of this as much as we can. Next slide, please. In March of 2016, there was new guidelines that were published by the CDC for prescribing opioids. Next slide. So why was this actually published? And we'll get to that, then we'll go to the different points about the guideline updates. But it was published in 2016, and the why is this. 20% of patients who were presenting to physicians' offices with non-cancer pain or symptoms or pain-related diagnosis received an opioid prescription. So 20% of patients were receiving opioid prescriptions. In 2012, healthcare providers wrote 259 million prescriptions for opioid pain medications, which was enough for every adult in the United States to have a bottle of pills of opioids. Thirdly, they saw that opioid prescribing had increased by 7.3% between 2007 and 2012, with opioid prescribing rates increasing more for primary care physicians as compared to other specialties. Another reason is because, as I said, back in the 80s and in the 90s, we were taught we were not being aggressive enough on treating pain, and so we responded. and the pendulum swung too far, so more and more was being prescribed. So as we look at the first 3 points with the CDC guidelines, that's really focused more on assessing the patient appropriately. First thing that they will say is that opioids are not the first line of therapy. And really what they emphasize is that opioids should only be prescribed if the benefits outweigh the risk. They say to consider non-pharmacologic therapy and non-opioid pharmacologic therapy, which we'll have another slide that will show what those will be. But if opioids are used, make sure it's being used in combination with those other treatment strategies. You also want to establish a realistic goal for pain and function to the patient. So this requires a lot of education. You want to discuss in advance about how to discontinue the opioid. And you want to do this prior to starting the opioid. You also want to talk to them about how effectiveness will be determined. Also, you want to establish treatment goals for the patient. Next, number 3 is discuss the risks and benefits before starting opioid and periodically during opioid therapy. We have to remember that our patients lack the information about the risk of opioids. I do have patients who come in who've had chronic pain conditions who are very concerned and very aware about the dangers of opioids. And so they were more informed about that. But we have a lot of patients who don't realize how easy it is to start using it on a more regular basis. And then you start feeling the euphoria of that medication, and now you're looking for that euphoric feeling. It may not be related to the pain anymore, but more that you're just looking for that. And then eventually, as we talked about, that might lead to withdrawal-like symptoms where you just don't feel good when you don't take it. Now you're looking for that on a more regular basis. One of the things that I wanted to emphasize too is that clinical evidence has found insufficient evidence to determine if long-term benefits of opioid therapy for chronic pain. So, long-term use is not something that has been shown in the literature to be a benefit for the majority of patients that are out there. Next slide. So as we look at this, it says use immediate release opioids when starting. There is a higher risk of overdose with the extended release or long-acting opioid products. And there's actually no evidence to suggest that the extended release or long-acting products are more effective, nor do they reduce the risk of opioid misuse or addiction. So really, the use of the long-acting is really for those patients who may have a chronic pain, a cancer pain, where you're trying to make sure that you don't have to dose as frequently, and then having the immediate release for more of the breakthrough. So therapeutically, that's where they would be used. But really for the patient in acute pain, there's really probably no need for using those and using the immediate release when starting this. You want to go with the lowest effective dose. Now we're getting from the patient, which is the first 3, now talking about the actual use of the opioids and what's the best way or best practices for that. When increasing, always reassess the risk and benefits. Also, you want to carefully reassess the risks and benefits if you're increasing the dose more than or equal to 50 morphine milligram equivalents. Then we also see to avoid increasing it too much, or greater than or equal to 90 morphine milligram equivalents per day. You also want to prescribe short durations for acute pain. And we've had some discussions with certain physicians, orthopedic physicians in particular, where they may be using it longer, which would make sense based upon what they might be treating. But then there's also some evidence out there saying for some patients who've had a broken limb that maybe opioids were not any more effective than utilizing some of the NSAIDs at a higher dose along with the Tylenol. So again, looking at the literature and trying to understand that. But the bottom line is to use the lowest effective dose of the immediate release opioid and then to reassess. And maybe for acute pain, if someone's coming in to the ER or coming in for an acute complaint, 3 days or less, not to give them a month's supply of the product, and then probably no more than 7 days is rarely needed. So not to overprescribe the number or the quantity that it sits in the patient's house and they start using it when they may not need it as much as they did initially. You'll also want to evaluate the benefits and harms frequently. Evaluate with the patients within 1 to 4 weeks of starting their therapy, or if you're increasing the dose. And then evaluate the patient every 3 months if they're using it chronically, and then consider de-escalating or tapering the medication at some point with a discussion with the patient. I bring that up because another story that I have happened when it was on a Saturday, and a patient, it was actually a friend of a patient who came into the pharmacy, and he was bringing in a prescription for 1,000 cc's of oxycodone liquid. I didn't know the patient. They were new to us. It's a Saturday, so now it becomes more of a challenge, right? Because I don't have the information on this patient. So I talked to the friend and saying that I need to verify this prescription. I asked why he didn't go to the regular pharmacy, which was at the university. They said because the clinic was closed. I said, I will try to call. I said, I'm not going to fill it unless I can get a hold of someone from that department. I was able to get a hold of a attending physician on that day from that department. And the physician said, let me check the record. And in the record, it had indicated that there was concern that the person no longer really needed this medication based upon his symptoms, and that there was some concern that he may be addicted to it. So at that point now, there's information that I have that I don't feel comfortable that I'm going to say that we're going to fill this. So I talked to the friend. The friend said, can you talk to my friend who needs the prescription? I talked to him. He says, I really need this. I need it badly. And I said, I'm sure at some point, and that this may be something you really need, but I can't fill this at this time because I don't have the relationship with you. And I think you really need to follow up with your physician to talk to them more about that. What was interesting is I checked the PMP on this patient. He was using this beyond what the dose was, and the dose that was on the prescription, he literally could use it if you use it around the clock, every 3 hours, PRN, so he could use it 8 times a day. Even if you use it as max dosed, he should still have had 7 days left. So I didn't feel like he was out of the medication. So I told him that, and what was interesting is then he said, well, that's not true because I only got half the amount filled. I said, what are you talking about? He goes, I went to another pharmacy on Sunday. And I said, well, that's interesting because that's not even showing up in your records. I was basing this upon the previous fill, which is we get into the prescription monitoring plan, we realize there is a lag at this time that can be up to 2 weeks when the prescription is filled and when it gets uploaded into the system. So it's not always the most recent information. So by the patient telling me that, I realized that he had extra there, so which even put more red flags on that. So we end up not filling the prescription and letting the physician know at the clinic that we told the patient to follow up with them as well too. Next slide. Next slide, please. Jen?
Give us just a minute on the slide.
Sorry about that.
That's all right.
I was worried that my mic stopped. The next guidelines are to use strategies to mitigate risk. And in Iowa, we do have a standing order now where pharmacies that are part of the standing order and have signed up for it can carry naloxone and give that to patients if requested. And naloxone is something that is for especially patients that you're concerned that they could be at risk of an overdose. Also, you want to be careful, though, with the concurrent use of benzodiazepines. There's some safety issues, and if you look at number 4 down there, it says avoid concurrent use of opioids and benzodiazepines. There's safety issues with the use of benzodiazepines with the opioids. Both of them are CNS depressants, and both of them can decrease the respiratory drive. So the concurrent use will put the patient at a risk of an overdose. If we got a patient that they need to be put on an opioid and they're on a benzodiazepine, if you can safely taper them off the benzodiazepine, that would be ideal. A safe tapering reduction for benzodiazepine is 25% every 1 to 2 weeks. But just remember, if they're taking both of those medications, there's going to be an increased risk for that patient. Number 2, and we're going to be spending some time on that as far as reviewing the prescription monitoring plan. You want to review the PMP data when starting the opioid therapy for chronic pain. And then you want to make sure you're reviewing that on a routine basis, at least every quarter, so you can see where they might be filling it. Because the patients might think that it's not getting into the system if the patient's paying cash, but it's uploaded to the system regardless if they're paying cash or if it's being paid by prescription. So you can see where they've gotten prescriptions, who actually wrote them, and then who actually filled them. Several physicians that I've talked to do urine drug testing. I haven't really seen a good guideline or guidance on on the best way to do that, and there could be some cost associated with that as well too. But it is a way to be monitoring your patients as well. And then also, obviously, if the patient is someone that you're concerned might be abusing the opioid, then offering them treatment for the opioid disorder and medication-assisted treatment, and also centers that you could refer them to. Next slide, please. The next thing we're going to review is just the management of patients with chronic pain. Next slide. So we talked in the earlier slides about the guidelines about alternative treatments, and we talked about non-opioid medications, and it was interesting, as I said, with one of the studies that we looked at, non-steroidal anti-inflammatory medications in combination with the use of Tylenol was pretty effective for patients who went into the ER, with a broken limb, and as compared to them being put on an opioid therapy. So there is some benefit to looking at that. We just got to make sure that the patient doesn't have other risk factors for other conditions, such as a GI bleed, or if they are we dosing them up with a PPI or some other medication to protect their gut? Obviously, if we've got patients who have some kind of neuropathic pain, we can use anticonvulsants or antidepressants that can help with that. Also, if they got some muscle spasms that's related to the pain, then we can use muscle relaxants as well. But we also need to remember that there's pharmacologic therapy options for patients as well too, which includes physical therapy, just increase exercise and aerobic exercise, or chiropractic treatments, acupuncture, injection therapies, TENS units, biofeedback, counseling. So there's a lot of things, but trying to get the patient to become more active may help with some of their pain complaints as well too, if they're able to do that. Next slide, please. If a decision is made that the patient's going to be prescribed an opioid, these are just some things as a checklist to say, do we have the information that we need to appropriately monitor this patient? And one is an opioid contract, which is an agreement form with the patient that contains statements to help ensure patients understand their role and responsibilities and conditions in which their treatment may be terminated, and also the responsibility of the healthcare provider. You have an opioid risk tool, which is a very quick tool that can be used to identify if a patient might be at risk of abuse, and then maybe rethinking if you're going to prescribe an opioid, and if you do think because the benefits outweigh the risk in that situation, very close monitoring would be indicated at that point. Making sure we know what the diagnosis is for the treatment so we can monitor, make sure the patient understands what are the functional goals with opioid use. Have we tried some alternative treatments for this patient? Do we understand the morphine milligram equivalents? If we are moving from one type of a medication to another, do we know how to do that accurately based upon dosages and moving from one opioid to the next? Understanding the side effects the patient may have and educating the patient about those side effects, the drug interactions that are possible with the medications, and then also making sure that you have looked at the PMP, and if you need to download information, downloading that information and keeping that within the patient chart as well too. Next slide. As far as record keeping, that's going to be important for healthcare providers, and this would be for all healthcare providers, is to make sure we have the information of the patient, the demographic information, the name and address of the patient, who the physician is that's prescribing it, when was the medication dispensed, what were the directions, any cautionary statements, what did you counsel the patient about, what was the medication, what was the strength, what was the quantity that you gave to them. Next slide. Obviously, from a prescriber perspective, making sure that we just have a good documented medical record that talks about the history, the pain history of the patient, the physician's examination, what the diagnosis was, and what the treatment plan, and that treatment plan was discussed with the patient. Next slide. As far as medical record requirements, need to keep accurate, timely, and complete records. As I talked about already, discussing the risks and benefits of using controlled substances with the patient, which include the evaluation, any studies, diagnostic studies that were performed, other treatment modalities, what's been tried, what's the plan for the patient, has the patient been informed? Have they signed off an informed consent that they understand? Was there a patient agreement or contract that was signed? Did we do a review? Did we do an opioid risk assessment? Are we doing periodic reviews? Are we documenting that we did periodic review? Do we document that we checked the PMP again? Any other relevant information to the patient's condition and treatment that should be added to that, just so there's a clear understanding. For example, we had a patient that was more in a gray area. I wasn't sure if there was an abuse issue. I just know that they seemed to be coming in a little bit earlier with their medications. I had sent a note to the prescriber, to the physician, letting them know that I was concerned, that I wasn't, I didn't have information on this patient to know how to adequately monitor them, because I didn't have the diagnosis, I didn't have the physician's treatment plan, and that started a discussion with the physician. And to this day now, the physician and I regularly correspond on this patient to be monitoring them on a more regular basis and sending progress notes to each other, so we both are keeping a good record and a good understanding of what's going on with the patients. That's been very helpful. Next slide, please. We talked about for those patients now who have problems. So, when we talk about the PMP, when you do the review or monitor the prescription monitoring plan, and maybe you do identify a patient who might be at risk, or like the patient I just talked about that needed their oxycodone, and then there was question if it really was providing benefit with them anymore. This is not a time for us to terminate care for the patient, but rather how do we help that patient get into a referral, get into a treatment that will help them overcome their addiction. And so as we look at in Iowa, different addiction specialists and treatment facilities, you can see that it's spread out pretty nicely throughout the state, but being familiar with and understanding where it might be located at, so there could be referrals of patients to those areas when we do identify a patient who might be having a problem. Next slide. Okay, we're going to focus now on the prescription monitoring plan and discuss how to use it, why to use it, what are the benefits of using it. Next slide. So according to the National Alliance for Model State Drug Laws, the PMP, or the Prescription Monitoring Program, is a statewide electronic database which collects designated data on substance dispensed in the state. It's housed by a specified statewide regulatory agency in Iowa. It happens to be the Iowa Board of Pharmacy, who actually administers and oversees the program for us. Next slide. So really, what is the purpose of it? It's a tool, and as I said, it's a very important tool that can be used to address prescription drug diversion and abuse. It serves several functions, and the first one, I think, is the most important bullet point, and that is it's truly a patient care tool. So it allows you to identify quickly if there's any issues with this patient. If there's no issues, now at least you know you're at baseline. What should you educate the patient about to prevent them from having some problems, as I talked about, with using it more frequently. Now they become more addicted, or they're starting to have withdrawal-like effects, so they're using it more chronically, which can lead to the addiction. But using it as a patient care tool in your assessment of the patient. So baseline, and then periodically if they're taking something on a more regular basis. But also as an early warning system, so if a patient is having an issue, you're able to identify that something is going on with that patient. It is for drug, to prevent or to identify drug diversion. Also an insurance fraud investigation tool. It helps prescribers, in particular, to avoid other medications that they were not aware the patient is taking or might be prescribed by somebody else that's popping up on the PMP. But it also identifies drug-seeking behaviors such as doctor shopping and pharmacy shopping. Because again, a lot of times the patient may not realize that by going to another place, they may not be familiar that the PMP is even in existence. And so when we do talk to the patients about it, we do talk to them about the PMP and what it is, and how the data is uploaded into that. So they're very familiar with that tool, so we can make them informed as we talk to them about what we're finding within that record. Professional licensing boards may use this to identify clinicians with patterns of inappropriate prescribing and dispensing. We'll talk about some of the updates that are going to be occurring within PMP, but one of them, and it should be within the first quarter of 2018, will be that there'll be like a report card system where you can identify, the prescriber can identify how do they compare to other specialists or other areas that they're focused in on to the other physicians as well too. It also can assist law enforcement in cases of controlled substance diversion. The bottom line is that the concern I think that people have is, who can this be shared with? And that will be the next slide, please. So who can access the prescription monitoring plan now? We got prescribers who can access it, which include physicians, nurse practitioners, physician assistants. We have pharmacists, and then we have designated agents, which are up to 6 per provider. It used to be 3, and they've increased that. Right now, to become a designated agent, the way the system works, and we'll show you that when we actually show the PMP, you actually have to fill out paperwork and send that in to the Board of Pharmacy. With the new updates that are becoming in 2018, this is something that can be done electronically, much like how a provider can actually sign up with the PMP electronically and not go through this paperwork shuffle. But right now for the designated agents, it is a paperwork trail that we have to fill out and send in. It's still pretty quick, but it's going to be easier in 2018 in the first quarter. What substances are captured in the PMP? C2s, 3s, and 4s are the substances that are captured in it. So that will include the opioids, the narcotics. It will include medications such as the benzodiazepines. So you can get a pretty good. It also include things that are used for attention deficit, so the methylphenidates and other products similar to that. So it gives you a good idea about what the patient might be taking. You can also see zolpidem or sleepers patient might be on. So as you review the information, again, back to a patient care tool, really understanding what the patient might be taking and that they may not be letting you know what they're getting from other providers. So it gives you a better, clear picture. But remember, it's just those controlled substances that are listed in C2, C3, and C4. Next slide. If we look at the dispensed controlled substances in 2016, we can see that hydrocodone, hydrocodone represents one of the biggest percentages at 22%. It'd be interesting to see if before it became a Schedule II, how much more it may have been, and I haven't looked at that. But even tramadol used to be non-controlled, right? And that's at 15% right now. And I wonder if that increased. We think it might decrease because of it becoming controlled, but it's not a C2, so it's not as regulated, so it may not be as much of a hassle to prescribe that one. So it's interesting that those are the 2 bigger ones as well. But you can see benzodiazepines sprinkled throughout that, which include lorazepam and clonazepam. Some examples, including the sleeper zolpidem that's out there. Alprazolam is at 9%. So there's just a lot of different medications. Obviously, the patient may be at risk of abuse, and so it's just something we need to be aware of. Next slide. There's always been discussion in the state of Iowa about should this be mandated. It's not mandated at this time. What this map shows is those states for which it is mandated, and if we look at the blue, those are states that require prescribers in one or more professional categories to register with the PMP, which represents 34 states. And if it's starred, those states that require pharmacists or dispensers in general to register with the PMP. You can see that Iowa is not mandated at this time. When I talked to the Board of Pharmacy about that, they made it clear that from their perspective, just mandating it doesn't make it that the physician or the pharmacist will utilize it. And so there's also states that have mandated that you actually have to use it as well too. So I think this thing's going to evolve because it is a tool. And I was asked at a presentation that I gave back in October about the legal liability by not checking it. And I had said, because this is a tool that is known, it is, to me, becoming the standard of practice. If it's not being used and someone has an adverse event or someone dies because they were abusing something and someone didn't check that and identify it, there could be some liability issues with that as well too. So it's just something for us to remember. It's a tool that can really help us improve how we evaluate our patients. Next slide, please. There's always concern about if the PMP is a privacy violation. Obviously, protecting the patient privacy is of utmost importance, and the Board of Pharmacy will tell you that. Even the patient themselves cannot get a copy of the PMP report. They can request it from the board. I can discuss it with the patient, especially this is the time for me to inform the patient why we may not be filling a prescription and what this report is. We can talk to them about it, but we can't provide them with actual copy. They have to get that from the Board of Pharmacy. So the Board of Pharmacy is, as I said, is about protecting patient information. Even if a police officer or law enforcement comes in and says that they want access to the Pmp report, they need to go to the Board of Pharmacy. That's not something we can freely give to them. But healthcare providers can access the Pmp, but only for those patients that they're treating. So, or those patients that they may be beginning to treat and might be new to them, so they can assess and see what's going on with that patient. There's also been questions about sharing of the Pmp report. Any healthcare provider actively involved in the patient care can get access to this. There's been questions about, can I send the report to another provider? But it can be if a physician or another provider and a pharmacist are working together. But what might be even better is that just both parties on a regular basis are actually accessing that database to make sure that they're keeping their own records up to date. Cannot be released to anybody else, as we talked about. And as I said, the patient can access it themselves. They have to go to the board themselves. Next slide. This is a slide that I had put together when we say, okay, so how effective is the actual PMP? And the three studies that I identified here, the first one is really looking at a specific area and looking at the PMP data used in emergency departments or emergency rooms. And this is one particular emergency room. What was interesting in this particular study, and this would be a case report for this particular emergency room, 41 cases had altered prescribing after the prescriber reviewed the PMP data. So 61% of the patients received fewer opioid medications than had been originally planned prior to reviewing. So obviously, reviewing the PMP altered what was prescribed for that patient based upon what the prescriber saw. And the second bullet was at one particular state, Kentucky, and they found that 90% of those surveyed who were utilizing the PMP or Casper, it was effective in preventing drug abuse, diversion, and also doctor shopping. And the last one is several states within a region that reported that PMPs reduce unwarranted prescribing and subsequent diversion of abused prescription drugs in their states. Again, as we look at the PMP on a regular basis, we do identify patients for which there just is too much of a question mark. As we get more information, we make a decision not to dispense a medication to them. And what's nice now within the PMP within the state of Iowa, we've got several states for which we could actually access their PMP as well too. We just check the boxes and able to look at a more broad region to see how the patient is doing. That becomes important because we've had some issues where some of the neighboring states where a patient thinks, okay, I'm going to go here because I've obviously used those resources way too much in this state and they know what's going on. But by looking at some of the neighboring states, you're able to have a clearer picture about what's going on with that patient and see if they've been abusing or getting prescriptions in other states as well. Next slide. So what are the benefits of the prescription monitoring program? It supports access to legitimate medical use of controlled substances, identifies and deters or prevents drug abuse and diversion, because if we're using it and identifying who might be at risk, but hopefully, ideally, we're being more proactive that we're identifying patients before we even prescribe, so getting to the source of the problem before it becomes a problem. Facilitate and encourage the identification, intervention with, and treatment of persons addicted to prescription medications. informing public health initiatives through outlining of use and abuse trends, and educating individuals about PMPs and the use, abuse, and diversion of and addiction to prescription medications. So it's just, to me, an overall good tool for all providers to be using on a more regular basis. Unfortunately, when it comes to pharmacy, if something's been prescribed and the PMP hasn't been checked in advance, now the patient comes in expecting to get something, and then we check it. Now we've got questions because it looks like they've gone to multiple physicians, multiple pharmacies. Obviously, that puts a pressure on the system. And then now we got to call that physician who prescribed it. It puts pressure on their system. Now they got to stop what they're doing, pull records on this patient, try to figure out what's going on. By being more proactive, hopefully we can become more efficient and more streamlined in how we're monitoring and taking care of our patients. Next slide. So here's some of the myths of the PMP. One myth is it's difficult to register. It is not difficult. As I said, if you're an actual provider, you just have to go online and you'll get the link to register and you get registered that way. As I said, if you're a designated agent, then that does require filling out a form and sending that in. But in the first quarter of 2018, that hopefully will be updated under the new vendor, so you can just do the designated agent online as well too. Another myth, it's difficult or time-consuming to use. That is absolutely not true. I literally can check something within minutes once I get into the system, and if I've been registered, I got my password and my username already loaded in. I get into the system, pull up the actual site to put the patient information in, which really requires first name, last name, and birth date is really all the information that's required. And then I can actually see how the patient is utilizing the controlled substances. So it's very, very quick, so you can make a good assessment that way. And, also, another myth is I don't have time to check the PMP with every controlled substance prescribed. As I said, it does allow you to have designated agents. The other thing that they're doing from an update perspective with the new vendor in 2018 is that this will be part of workflow, so that you'll be able to put it right, hopefully access it right from the electronic medical record to just make it easier for people to access instead of having two different places that you have to jump out of the medical record and go into the PMP. Next slide. What are the challenges? As we talked about, lack of mandatory registration because people may not be using it, but hopefully with sessions like this and going around the state and talking to other providers about this, the importance of utilizing it, hopefully we'll see an increase in use and uptake of using the PMP. As I talked about, there is a gap between reporting when the information is entered. It may take up to 2 weeks before that information is entered. What I've heard, I think, with the update, they're trying to reduce that, but it really depends upon how the information is uploaded from the pharmacy into the system, and if there's any information that's wrong, it stops the process until that information is corrected. So as I said, there may be a gap, but it will give you at least a good guideline, and you just may be missing the last 1 to 2 weeks. So take that in consideration as you're talking to the patient. Next slide. So I talked about the future of the PMP. The Board of Pharmacy is in the process of updating the software. As I said, hopefully by end of first quarter of 2018, it will be more user-friendly, easier to pull data, part of workflow, and easier to upload and get designated agents registered into the system. Next slide. The last thing I want to talk about is how do you actually utilize the PMP. So we'll just kind of go through some of the screenshots to show you that. Next slide. So this is where you start, and for me, because I've put my username and password in, then it is always loaded up for me, so I can get into it right away. But this is the login screen. Log in if you're registered. If you've forgotten your password right now, the challenge is you have to call the board and they have to get you a new one. And if with a new update, they're hoping that you can do all this online if you forget your password, to be able to access a new password that way. So literally I have to call, because I've forgotten a couple of times when I got a new computer and I didn't have my password uploaded. And does take a little bit of time, because if I'm asking for that and I want to check on a patient right then and there, I don't have that. Luckily, I have other pharmacists and other agents within the pharmacy can access it for me. But that's the issue, is just making sure you can quickly get a new password if you need to. Next slide. So once you put the information in and you get into the system, these are the things that you're going to see. And you can see on the upper left-hand corner, there's a request, which you're going to request the information that you're looking for. You can look at other links on the left-hand corner in the next tab down, where you can look at messages or alerts that the Board of Pharmacy has put into there. You may put alert in there as far as a patient that you may be concerned has abused or has a false prescription, whatever the case might be. You can put that information into the system, which will alert the people who are part of the PMP that something is going on. If you've got any questions, you can go into your account, look at that, and there's also a help button, which is on the far right-hand side, the question mark, for which you can get information. Next slide, please. All right. So now this is where the request for information is going to be at. So this is where I'm going to put the patients. You can see that the things that are starred, the little red asterisk, last name, first name, and birth date are the absolute required information. Put that in. Hopefully the spelling is correct and everything. And then once you put that information in, you're going to hit view request, and that information will pop up. When you're submitting a request for patient history, the date defaults to 12 months. You can see that under prescription range. You can change that if you like, and you can see the number of states that are listed there. And this is actually an older slide. I know there's been a couple of more states that have been added to this, that you can check those states that you're interested in looking at. But just remember, the more data and more PMP information from other states that it has to pull from, it may take a little bit longer for that report to generate. Next slide. So this is what will happen once you put in the information, and we've got the patient's name and birth date. And then you'll see an attachment that says Patient RX History Report, which will give you the information. So you just literally will click on that, and that information will pop up. Next slide. If the response indicates that your request could not be processed automatically, don't resubmit. This is at the time then you should call the PMP administrator at the Board of Pharmacy, and they'll process your request as soon as possible. But literally, it's just an attachment, a PDF attachment, that you just click on that. Next slide. And this is what the PDF report will look like. So in this case, we got a patient, and you can see the dates. Obviously, this is just an example. See dates when they got things filled with the hydrocodone and clonazepam filled in January and March. And then previous to that, back in December, they had a hydrocodone and Tylenol combination product that was prescribed. Literally, if you've got a patient who has been going to multiple prescribers, multiple pharmacies, you can get a pretty lengthy report, especially if it's the last 12 months. So it does take some time sometimes to go through the report to really identify. And we've had situations where we're actually looking at it very, very closely to find out, are they getting things filled early? So looking at the refill dates, the quantity that they're getting, and just making sure you have an understanding. So I try to make sure I'm fully informed, so when I go and talk to the patient, that I have the questions I want to ask them. Again, informing them that we're looking at a database called the Prescription Monitoring Program for Controlled Substances, and that we're looking at, where they're filling things and who they're getting prescriptions from, as a tool to make sure that we're assessing their therapy appropriately. Some patients have been upset. Some patients seem to understand. But at the end of the day, this is a tool that is available to us to assess our patients. So it's not something that I apologize to the patient. It's something I say this is part of our assessment of the patient. And so we do this on a regular basis. Next slide. And there's a user guide that the Board of Pharmacy can provide to assist you in learning how to use the PMP. The best way I think to use it though is just to get into the PMP and start using it, monitoring your patients, and that will help you to get more experience and comfort with going into it on a more regular basis. And I appreciate it. And Jen, I will pass that on to you.
All right, thank you very much, Randy. We do have a couple questions. One coming from a participant. If you are an agent on the PMP under one provider and might work with an alternate provider as well, can you look up information on the alternate provider's patients?
You know, that's a good question. That actually should be, I'm going to pass that on to the board because I'm not sure. I think if you're a designated agent, you can only for that particular provider be designated for. So you just want to be careful with that because that information is protected. So I'm writing that down as a note. And Jen, I'll pass that information on to you to send out to the group.
Perfect. And then another question, what is the argument against mandating the PMP in Iowa? How close are we to getting this mandated in Iowa?
Good question. I think probably just the politics of it all, right? I don't think people are averse to making it mandated. When we talked to the board about it, they couldn't give me a reason why they wouldn't. Their comment just was, even if you mandate it, doesn't mean people will use it. So I think that's something that, you know, the discussions are still going on. But it may just be the politics and what you have to do to get those rules passed, because that's not always an easy thing. And if providers are not on board on using this thing, they may fight back. So it's something that we just have to make sure everybody's on the same page as we look for that kind of regulation.
Great, thank you. Any other questions or comments for Randy? All right. Well, thank you very much, Randy. I really appreciate your time, and I know you'll be working pretty closely again with the Opioid Guardianship Project, so we appreciate your work with that as well.
Thank you.
So we're going to go ahead and move on. We are going to take a short break here, and we will get back together in about 10 minutes at 10:40. Just a reminder, if you are wanting CEUs, do not log out during this break. Otherwise, you will not show as participating for the entire workshop. So again, we'll break for about 10 minutes and reconvene at about 10:40. Thank you.
to communication and optimal resolution, also known as the candor process. Starting in January 2018, Compass HIIN, working with the Iowa Medical Society and the Iowa Hospital Association, is going to begin a cohort project with interested hospitals, working to implement the candor process and identify effective strategies for uptake. So I urge you to listen to Dr. Mcdonald's presentation today and consider whether or not your facility is ready to join one of our upcoming candor cohorts. And if you are interested, please contact me. I'll make sure my contact information is made available for everybody on the call today. As I mentioned, our presentation today comes from Dr. Timothy Mcdonald. Dr. Mcdonald is the Director for the Center for Open and Honest Communication at the MedStar Institute for Quality and Safety. He's an internationally recognized patient safety expert and was the inaugural Chair of Anesthesiology and Medical Director of Quality and Safety at the Sidra Medical and Research Center in Doha, Qatar, an ultra-modern 400-bed maternity and children's hospital, and an affiliate of Weill Cornell Medical College that he helped open in May 2016. Tim is a physician attorney who has been involved in patient care activities for the past 30 years and patient quality and patient safety efforts for the past 20 years. He is a recipient of many national and international awards in anesthesiology and patient safety, including the American College of Medical Quality's Founders Award, the Institute of Medicine Chicago Patient Safety Award, and the Hope Award from the Medically Induced Trauma Support Service in Boston. So with that, I will go ahead and turn it over to you, Tim, and we can get started.
Great. Thanks very much. So should I go ahead and share my screen and run the slides, or do you want to?
Yes, you go right on ahead.
Okay. So let me. All right. So you should have my slides, I hope.
We do, yes.
No, great. All right. Well, thanks very much for inviting me to be in this this webinar. It was really great to see all the fantastic work that that you've been doing, to see your data. The other part that is exciting to see is all the progress you've made in the last few months with the work around patient and family engagement. And if anything, I would say that the whole candor approach is something that really, at the heart of it, really is patient and family engagement. So outlining what the problem is and what we sought to be many years ago, and as Macri has recently published, medical errors, if you just consider them as its own diagnosis, preventable medical harm as its own diagnosis, and you put it into that bucket, if you looked at all of those deaths related to preventable harm, it would now rank third as in terms of the leading cause of death behind cancer and heart disease. So it is a significant problem. What we discovered many years ago, and I have a story to share related to that, is that all too often when these catastrophic events happen, or other events that happen that in the mind of the patients and families is a very serious one, all too often we build a wall of silence. And the wall of silence is not just built around patients and families, but also around caregivers. Often what happens is when these events occur, many members of the care team, as well as patients and families, suffer in silence. And it has made things significantly worse when we encounter these preventable harm events. So we had one case in particular at the University of Illinois in the early 2000s, which was that sort of case that really changed us forever and put us on a path for the last 15 years to find an antidote to this wall of silence. And it involved the COO of our sister hospital, Michael Reese Hospital. This woman was the COO there, and she came to the University of Illinois for pre-op testing in preparation for her marriage. And her pre-op CBC showed a white count of 1,000, which is significantly low. It's not critically low, but it's significantly low, and it should have caused us to pause and consider something perhaps going on with her that, should have had to step back and not necessarily proceed with this elective plastic surgery that she had. And we didn't act on it. We didn't act on it in anesthesiology. That was the department I was working in at the time. And in addition to that, it wasn't acted on by the surgeons or any of the pre-op clinic people who were there. And so she undergoes the surgery. During the surgery, she did lose some blood. She received a blood transfusion, and she ended up getting a post-op CBC that now showed a white blood cell count of under 500. Many of you on this webinar will know that this particular level of white blood cell count it's a critical test result. Patients who have white blood cell counts of under 500 are at risk of sepsis and other things happening. But once again, we didn't act on it. It turned out to be a horrible systems error. We're not fully sure how ultimately it happened, but the white count, because it was critical, was called by our lab to the floor where she was, but it was called to a person whose first name was Mary at a time when we did not have a Mary working on that particular floor. So we didn't act on it, and unfortunately, this person dies 6 weeks later at Northwestern Hospital with a treatable leukemia. Because so many of us in Chicago work fairly closely with one another, one of the members of the leadership of Northwestern called the University of Illinois, got a hold of us in the Office of Patient Safety, which is where I was spending a fair amount of my time, and told us that this particular person had died there and wondered whether there was any evidence 6 weeks prior when she had surgery at our organization, whether there was something there. And of course, we went back, we looked at the medical record, and to our horror, we discovered that the white count of under 500 had never been reported and never been acted upon. And we did not reach out to the family as we had wanted to, many of us wanted to. The legal system, as well as the leadership of the organization, recommended that we maintain silence and hope that it would go away. But it did not go away. We ended up being sued, and we did what we would describe as delayed, denied, and defended this care, in many ways, this indefensible care, for over 4 years. We spent a ton of money. Eventually, we settled for millions of dollars. And unfortunately, we learned little and we suffered immensely. And this was occurring at a time in the early 2000s where there was evidence that places like the University of Michigan, places like the VA hospital in Lexington had taken a different approach of being open and transparent when these sorts of events happened. And with the combination of that sort of evidence that was out there and us suffering from this horrible event, fortunately, we were offered the opportunity by our board of trustees to consider looking at a different way of approaching these patient harm events. And what we've learned, which is what we've learned a lot about in quality and patient safety, is that culture does indeed eat strategy for breakfast. You can have the greatest plans to prevent harm, you have the greatest plans to communicate better, engage patients and families, but if the culture isn't ready to embrace this sort of activity, any strategy that one puts together is doomed to fail. And what we discovered in this culture is that this wall of silence creates a great deal of collateral damage. We call it the unkind acts cascade. And if on this slide, you look at the left, when we tell families to speak to the hand, it has a horrible impact on immediate family members and even the extended family members. In fact, recently I was reading that couples, married couples who lose a child to preventable harm, the likelihood of them divorcing is about 90 to 95%, particularly when, again, they suffer in silence. And we're now learning more and more about the collateral damage also to the clinicians, to the pharmacists, to the nurses, to the doctors, to all the people in the care team, that when these events happen, if there isn't a principled and comprehensive approach to both supporting patients and families and caregivers, its impact on burnout, its significant impact on these clinicians is having an incredible, and taking an incredible toll on them. In fact, there's a woman named Sarah Charles, who is a psychiatrist at the University of Illinois. She wrote a book, as you can see here, called Defendant. And she describes what it was like for herself to be charged with medical malpractice. This occurred after one of her patients had tried to commit suicide, ended up a paraplegic. And again, she was advised by legal counsel to not talk to anybody after the harm event, and then even going beyond when she was sued. And she talks about this feeling of isolation from colleagues and from patients. And as a psychiatrist, really began to understand that what she was experiencing were common reactions of most doctors, and it turns out most anybody who's been accused of negligence. And in the book, she again describes this impact of the wall and how it swallowed up her life. It demanded constant attention and study. It generated a broken, pattern of broken sleep, and she felt her integrity as a person had been damaged and permanently lost. And it caused her to really think about how we really didn't have many things in place at all up until fairly recently to really support the caregivers after these events, and particularly when the possibility of legal activity might ensue. And so if you look at these symptoms here of associated with burnout syndrome, you can see that Sarah was suffering from many of the psychological symptoms and the physical symptoms in terms of her insomnia, feeling exhausted, and then also, being and feeling overwhelmed and unprofessional and hopeless. And the reason this has become so important is because of the significant increase recently, as you can see here, in the changes in burnout. If you look very at the top there with emergency medicine and OBGYN, the light blue on this graph shows the increase in the percentage of burnout over just the last few years. And so you can see, again, a substantial increase from 2013 to 2017. And you look at the emergency medicine, the OBGYN, the family medicine, all the way down really until we get to gastroenterology. In all of those specialties, at least from the physician's perspective, more than half are suffering from serious burnout. And this has a substantial impact on patient safety. It has a big impact on the outcomes for our patients. And there's obviously a lot to contribute to this. Certainly, we've read a lot about the work around meaningful use and what that has done to take, in many ways, the doctors and the nurses and other people away from the bedside of the patient. But there's also been the ongoing descriptions of the people who have suffered in this way, not having an outlet, not having that opportunity to work with patients and families who may have been part of harm events that were preventable, or themselves getting proactive peer support. And this recent article that AHRQ put out showed a study where they looked at, and this was in Europe, but they looked at and measured the degree of burnout amongst physicians and nurses in particular units. And what they found was mortality rates, the highest mortality rates were in those units where burnout was also the highest. Again, getting to the whole massive collateral damage that happens when we're involved in these particular harm events in the healthcare setting. And so thanks to Rick Boothman, we were given the opportunity in 2004, after that death of our chief operating officer, Michael Reese, to think about a better way to react to and manage these harm events. And Rick, who was the chief safety officer at the University of Michigan, published a lot of the real early data on this, had invited us in 2004, 2005 to come to the University of Michigan and see what they were doing that seem to be having such a big impact on both their patient safety and their liability outcomes. And so what he shared with us were these essentially 4 principles of this comprehensive approach to the prevention and response to harm. And as I sort of look at these, it's pretty hard to argue with any of them. There's one in particular that's a little bit complicated, but these are the 4. The first is that when harm occurs, we will provide effective communication rapidly following all serious harm events. We will then apologize and fairly and rapidly resolve all cases of inappropriate care. And of course, the big question there is, how do we determine inappropriate care? We will learn from our mistakes, and then finally, we will support patients, families, and caregivers throughout this entire process. So these were the fundamental principles that we worked with at the University of Illinois, and we worked with the folks at the University of Michigan and others back 12, 13 years ago to really figure out and hardwire a comprehensive response. When we initially designed this, in many ways, it was sort of like a Sorry Works program, which is what you can sort of see here on this particular slide, where initially it was the event happens, we assess whether there's harm. If there is harm, we'll look into it, investigate it. And if we make a determination that our care was inappropriate, we would then reach out, apologize to these patients or families, and then try to come to some sort of remediation or resolution. And of course, that was where the whole system kind of stood. And when we initially approached many of the patient advocates who are part of your PFACs now, and we presented this approach to them, it was highly, highly criticized. Many things were missing from this picture from our standpoint. And this is the feedback we got, again, from patients and families, that this just was not an adequate response to patient harm. And what were the things that were missing? Well, you can see there's no process improvement on this particular diagram at all. There's no situations where non-harm events are analyzed or improved on. There's no place here for the harm events to go into any kind of process improvement situation when there's no harm. And in addition to that, the other big problem related to, if you follow this diagram, we were waiting until we'd made the determination of inappropriate care before we were ever reaching out and speaking to patients and families. And so one thing we learned from patients in this case and family members who'd lost loved ones is that every hour that goes by without effective communication is another harm event. And particularly if in a case of serious harm or death. And so we realized we needed to totally rewire and relook at the way that we were beginning to approach this. It took us about 1.5 years. We had a lot of input from many people throughout the country who helped us put together what we first published as the 7 pillars. A total redesign in the way we were now going to respond to events, whether they were harm events or not. And this is what we published in the Journal of Quality and Safety in Healthcare, and this is back in 2009, 2010. And so you can see here in the upper right, these events are reported into safety risk management. If there's no harm, it would go to a database, but you can see dotted line over, we would still treat these as near misses worthy in many cases of significant process improvement. If there was harm, this is when we completely revamped our process where we began to consider the second patient or the second victim, which is the people within the healthcare team who may be seriously affected by these significant harm events. Even while we're beginning the event investigation, we would begin that opportunity to speak to patients and families almost immediately. And one thing we learned right away is the need to hold bills with serious harm events. We had one horrible case at the University of Illinois where we operated on the wrong side of the brain of a patient. We did apologize to the patient and to the family and continued to communicate with them, but we had a significant internal breakdown within finance. We sent bills to the patient and ultimately sent that patient to collections, which was not a very good process. So we totally internally redesigned that in a way where we were notifying both the private physician billing companies as well as the hospital that these events had happened, to put the hold on the bills until we could determine whether these are the kind of cases we would bill for, or we would need to manage differently because the care was bad. The other piece that we learned very early on is this need to have immediately available people who are well-trained in communication. These are people that we were able to use a communication skills assessment tool to identify as super communicators who could serve as a patient communication consult service 24/7 to those who needed help, needed coaching, needed a consult in how to communicate after one of these significant events. And this became the mainstay of our program, is having these few people trained to be able to assist others in the organization that had these horrible harm events. This is not unlike having a cardiology consult service where you have people highly and well-trained in cardiology able to respond right away. This is where the patient communication consult service kicked in immediately. And then what we would do is continue to communicate until we'd made that determination of whether care was appropriate or not. And if it did turn out that care was inappropriate, then we would explain to the family all of what had happened. We provide an apology, and we would move forward with some sort of remediation, both financial and non-financial, in the cases of inappropriate care. If care was deemed appropriate, we would still resolve with the patients and families, but that was through open communication, sharing all of the medical record, and explaining to them why we believe the care was appropriate. All of this was done in the context also of, in these bad cases, activating a crisis management team, again, available 24/7 to help people within the organization manage and deal with some of these terrible events. And so, again, this was the 7 pillars that was published, and very early on, we began to see many significant changes, both on the patient safety side as well as on the liability side. On the patient safety side, we saw a substantial increase in the number of event reports, many of these coming from learners, nursing students, medical students, and resident physicians who found the culture safe enough that they could report and that something would be done about the event reports that came in. We saw many significant process redesigns that led to a substantial decrease in many kinds of the serious safety events that still plague us today. And again, on the liability side, we saw an almost immediate reduction in our claims and our lawsuits and the cost associated with that kind of approach. And so what happened after President Obama was elected, he put out the call for demonstration projects to look and see whether or not these kinds of approaches, like Michigan, like the U of I, like Stanford, like Lexington VA, could in fact be replicated in other organizations. And that led to, over the course of a few years, many wins and more money that was put into the development of a toolkit around this, what we call comprehensive, principled, and systematic approach to the prevention and response to patient harm. And so the Communication and Optimal Resolution Toolkit was created, and with a whole lot of input from people all over the country who are experts in the various domains that you can see here. Those in the domains of identifying these serious harm events, the way that a system can be activated very quickly so that there is, as you can see at the top, this immediate response with communication, both with patients and families and also caregivers. And as you can see in the circle in the middle there, that as you investigate and analyze and as you learn more, you share more. And as you learn more, you share more, until ultimately you have learned enough about the organization that you're prepared to move towards resolution. And as I mentioned, that resolution may be just explaining to the family how horribly sorry we are that this event has happened, but that here are all the medical records, here's what happened. We really do believe, with what we've looked at and the rest of this sort of work, that our care was appropriate, and that we'll continue dialogue, we'll continue communicating, but that's our view of how this needs to be resolved. In the other cases, like we discussed, the care may be inappropriate. We would then try to reach forward with some sort of resolution that may be financial and, in fact, or may be non-financial, depending on what the needs and the severity of the harm is that's occurred to the family at this time. I'm going to go back to this slide. I can't undersell this notion of having super good communicators involved in some of these conversations. One of the cases that sticks out is one that we had a few years ago, and you can imagine how nice it was to have this approach hardwired, is we handed a baby to the wrong mom at 4 o'clock in the morning. And at 5 o'clock in the morning, when the nurse went back into the room, she identified, and the parents identified, that the mom was breastfeeding the wrong baby. And so this is a situation where the nurse immediately recognized the need to activate our crisis management team, going up through her charge nurse or supervisor, immediately getting a hold of those of us who were available and around overseeing the communication consult service. When she called us, what we identified initially was a need to communicate with two sets of families. One is the family where the mom breastfed the wrong baby, and the other, the family where the baby had been breastfed. And we identified at that time the person who was on call for OB was one of the people that, when we had done sort of our skills assessment, was what many of you may in the call may recognize is the last person in the world that you'd want to be talking to these families. This was the kind of person who we already knew generated a fair number of patient complaints, and we've been working with for quite some time. And I was actually a bit terrified about having them take the lead in this conversation. So fortunately, that was not the only person on call for us. We had somebody in the house, a guy named Mark Potter, who is one of our great family medicine docs, a brilliant communicator, who we were able to reach out to and said, Mark, we need you to reach out to these families and have a conversation with the nursing staff and explain what it is that happened. And he's such a skilled communicator, and his conversation was so empathic that we were able to manage the emotions and the needs of those families without the need to pursue any kind of litigation, without the media being called and the rest of it. It was a pretty remarkable experience for us, for him to be able to do that. And importantly for us, several years later, we were doing this talk with the medical students at the U of I, the largest medical school in the country. And it turned out one of the people in the audience was one of the women who Dr. Potter had to communicate with. In fact, she was the one whose baby had been breastfed by the wrong woman. And she was so impressed by the process and by the empathic communication. She actually reached out to us after that lecture. She stayed in contact and has since graduated from a primary care residency and serves currently on the patient communication consult service as we speak. So amazing opportunity to pay it forward and change the culture. So anyway, as I mentioned, the Communication and Optimal Resolution Toolkit came out in May of 2016. Importantly for Iowa passed its own medical liability reform, the Candor Bill. It passed in July of 2015, and we just had a conference a few months ago to get an update on how this is working in some of the hospitals who've implemented this approach. Very novel legislation that does a lot to break down the barriers and make it easier for hospitals to have these kind of conversations in a way that's confidential. It protects all the parties involved, include patients and families, in trying to reach a reasonable resolution. So again, Iowa's leading, particularly with this kind of legislation that's out there. This all represents a huge paradigm shift. moving from reporting that used to be delayed to one that is immediate and often through a hotline or some other methodology to get this consult service when it's needed for the serious events. Also, to move from our communication that used to be delay, deny, defend, and the wall of silence to immediate and ongoing in sharing information with the patients and families in a fully engaged manner. Moving our event reviews from shame, blame, and train to those that are focused on human factors, process, redesign. This is the real key to candor, which is the learning that comes from this opportunity to be fully transparent in your organization. And the care for the caregiver part, from suffering in isolation to the provision of immediate and ongoing support to caregivers. We were at a sort of a workshop last night, a panel discussion, a lecture in Maryland last night, and a lot of people showed up, and all over the organization, people were there to talk about how powerful this program is that goes beyond doctors and nurses and pharmacists, but all the way down to the folks who work in environmental services and the folks who work in the cafeteria, who see bad stuff every day and may be emotionally traumatized by it. And this care for the caregiver program that's part of the implementation, as it turns out, is one of the most popular, particularly for the physicians and the nurses. And in the domain of resolution, from having patients and families having to fight for it, to making that early offer, but when and only when you have full consensus that care was bad. And so this is to create that cascade of candor, kindness, moving away from the unkindness that we have seen so often when these sorts of things have happened, that again can have a big impact on the emotional well-being and the amount of kindness experienced in an organization. And in fact, this has been studied, this physiologic impact of kindness on many different things, often mediated through the vagus nerve. And it's pretty impressive for organizations that really build on and build this focus of resilience and wellness and care for the caregiver, what can happen. I have a couple of studies that are pretty amazing. One of them is around the improved immune response. There was a study done looking at many members of a particular hospital, studied the 4 weeks prior to getting their flu shot and 2 weeks afterwards. And what they found with high statistical significance is those who were in an environment of kindness, who had that more positive mood prior to getting the immunization, had a much better immune response than those who did not, showing again that the impact of the candor program and having this kind of kindness approach can have a big, far-reaching impact far beyond even some of the basic patient safety and medical liability outcomes. So the data that's recently been published from Massachusetts, from Illinois, from Michigan, from throughout has shown, again, strong data that this improves the patient safety metrics, but also a significant decrease in claims, liability costs, and really importantly, this would go back to Sarah Charles's perspective, that time to resolution has continued to decrease from years to sometimes just several months from the event until you have full resolution, which really helps the healing of both patients and families and caregivers. And then finally, we published an article in Health Services Research showing that the physicians who've gone through this kind of training and been fully immersed actually practice, compared to their colleagues, significant decreases in the items that are related to defensive medicine. So that is the kind of the data that we have. What we've now done with the toolkit since May of last year, we at MedStar and other places throughout the country are working with over 200 hospitals throughout the country in the process of now implementing the candor approach, which is sort of a stepwise approach that includes doing a sort of needs assessment of the organization, the gap analysis, and then working with the leadership of the organization to build out these domains of human factors event review, communication consult teams, the care for the caregiver team, and ultimately working with the various kinds of lawyers in the community, as well as lawyers with the organization or in the group practices, to find ways to come forward with more appropriate resolution, again, as I mentioned, particularly when care is bad. And so from that standpoint, I think I'll stop my share now, Jen, and then I guess open it up to questions that folks may have.
Great, thank you very much, Tim. Do we have, right now I'm not seeing any questions in the chat box or the Q&A. Do we have any questions or comments for Tim? Do we have any hospitals that are on the call today that are currently using candor practices within their organizations? Tim, we have one comment here from Marty, and he says, would you like to say more about how people identify their super communicators?
Right, and I see Marty's comment as well. Dignity, the Dignity Health System, which has about 40 hospitals, they've begun to roll this out in all 40 of their hospitals in California and Arizona. And so there is if you go to the candor, the toolkit is at AHRQ's website, and it describes this communication skills assessment, which if people take it, you are able to, again, identify those people who score particularly high in this communication skills assessment. And what Dignity has done is they have tapped into those people who scored super well and built them into their communication consult service. So that's one of the things that is used for those organizations that want to move forward to do this. The other part that Marty has asked is about the implementation of this. And again, we found this with Dignity. There was no need to add any more FTEs to their particular quality and safety infrastructure. It was really just a matter of repurposing and redesigning a lot of the ways they reply to patient harm, and without necessarily a need to increase again, the number of FTEs of folks that may be working in the quality or patient safety domains.
Great, thank you very much. Doesn't look like we have any other questions or comments. So with that, thank you, Tim, very much. We greatly appreciate you speaking on today's event. And just a reminder to everybody that we will be moving forward after the first of the year with some candor work here in Iowa with all of our hospitals, or with a subset of hospitals, and doing some collaborative activities with Iowa Medical Society and the Iowa Hospital Association. So more to come on that. If you have interest or would like some more information about some of the candor work that we're going to be doing over the next year, please reach out to Stacy Klinker, our project manager. And Marty, it looks like he also posted the link for more information on Tim's work that he is doing with MedStar, and we will be sure to post that link and information to Hinnovation for everybody to access as well. So thank you, Tim, very much.
You're welcome. Thanks for having me.
Not a problem. Thank you. So with that, we will move on to our next speaker here, which is Janet Lacey from Grinnell Regional Medical Center. Janet will be presenting on the work that they have done with patient and family advisory councils and sharing some of their lessons learned. Janet serves as the Director of Patient Experience and Quality at the Grinnell Regional Medical Center. She's a graduate of Iowa Methodist School of Nursing and has held a variety of positions in the field of nursing, including staff nurse in pediatrics, med surg and ICU, obstetrics nurse manager, director of nursing, and director of admissions. She's worked at Grinnell Regional Medical Center for more than 40 years and promotes patient, family, and employee engagement throughout the hospital. So welcome, Janet. Are you on the call? Janet?
Yes, I'm here.
All right. Okay, great. We can hear you now. So I'm going to go ahead and...
Do you want me to share my screen?
I can share from here, and we can go ahead and run it from here if you're all right with that.
Okay, there's just animation on some of them, so just click through it.
Okay, I can do that. All right, can you see your slides?
I can, thank you.
Perfect. All right, so I will hand it over to you.
All right. Well, Grinnell Regional Medical Center is a 49-bed hospital, and we're located just north of I-80 and kind of sit right in between Des Moines and Iowa City. We're kind of called what's a tweener hospital, which means we have too many beds to be classified as critical access and not big enough to be an urban hospital. And tomorrow we're excited to be celebrating the 50th anniversary of the consolidation of a Catholic hospital that was located in Grinnell and the community hospital. And at the time of that consolidation, there was a lot of controversy and hard feelings, but that's all in the past now, and we have an amazing support from our community. And today I'm going to share an example of that with our Patient Family Care Council. Next slide, please. So this is kind of the story of Grinnell Regional Patient and Family Care Council and how it started. And I'm very excited to be able to share this information with you. I know that, and I'm sure all of you do too, our days are full of meetings. Some of them are more enjoyable than others, but I have to say my favorite of all is our Patient Family Care Council. I always look forward to it. We started our Care Council journey back in 2006. 5 years earlier, we had a customer service initiative that had gone very well, but it was starting to lose momentum. And we were looking for something to kind of re-energize and step up with our patient experience. So I had read about patient family care councils through the Plane Tree organization, and it happened that our CEO about the same time had heard about patient family care councils from a conference he was at, and he came back and we got to talking about it, and he gave me the go-ahead to just go ahead and do whatever I needed to do to get it done. So then the hard work started. So I wanted to do it, but I wasn't quite sure where to start. And 10 years ago, there wasn't a lot of information about PFACs out there. So I turned to the Plane Tree organization, went on their website, and they had a lot of great information. And I pretty much based our care council on what they had and then tweaked it so that it worked for us. And I highly recommend the Plane Tree organization as a place to look for information. Next slide, please. So you want to hit it again? So this is a quote from the Plane Tree founder, and she says, "What patients want is not rocket science," which is really unfortunate because if it were rocket science, we would be doing it. We are great at rocket science, and we love rocket science. What we're not good at are the things that are so simple and basic that we overlook them. So that's what we needed to do to start our patient family care conference, to get away from the complexity and confusion of patient care and just get back to the basics. Right, if you'd like, next slide. Okay, so we knew what we needed to do. So our next question was, why do we need to do it? To be able to explain it to others, to physicians, staff, potential council members. What are we trying to accomplish and how can we bring them on board? And I found these two quotes that really summed up what we were trying to get across to people at that time. This one's, "Let the young know they will never find a more interesting, more instructive book than the patient himself." Next slide. And we spend a lot of time designing the bridge, but not enough time thinking about the people who are crossing it. So we had the what and the why. The next question was how. How are we going to, where do we start? How are we going to create an effective patient family care council? So what we did was we created a vision and a mission. We wanted to state our values and make sure they were included in what we were doing. We designed a strategic focus, and we created our council structure. Our goal was not to just care about our patients, but then to include them in our care. Not just do things to them, but do things with them. And see the patient as a unit that involve families and whoever the patient chose to be their support person. So first was our first goal was to create a mission and a vision. Next slide. Our vision was to be an advocate and serve as a voice of the patient and family of all who receive health care from Grinnell Regional Medical Center. And our mission was to work side by side with all healthcare providers to ensure the highest level of all aspects of care is delivered to the patients. Next slide. Then we looked at our values. We wanted to treat our patients with dignity and respect, and to listen and honor to our patients and the family's perspectives and what choices there are. And when I say family, I mean any type of support person that is with that patient. So many times we talk about the golden rule, do unto others as you would have others do unto you. But we want to listen to the patients and not do maybe what we think is best for them, but what is best for them, what they want. Information sharing, we wanted to communicate and share timely, complete, accurate information in order to effectively participate in care and decision making. Participation is our third value. If you want to click, Jen. Patients and families are encouraged and supported to participate in their care and decision making. And the last one is collaboration. Patients, families, and providers collaborate in the policy and program development. And we've done that a lot with our Patient Family Care Council. Next came our strategic focus. We wanted to we wanted the council to provide us with information about patient and family needs and concerns. We wanted their help in planning new care areas and programs to be more patient-friendly and focused. We wanted to encourage patients and families to be more involved and speak up when we have concerns. We wanted them to help us strengthen the lines of communication between community and Grinnell Regional. It took a lot of education at first to, it took a lot of education to get them used to being involved. I am so sorry. I thought I had that on Do Not Disturb. I'm sorry. I'll call you back. To know that it's okay to ask questions and make suggestions. And it's some of them are reluctant to do that. Some of them just want to be told what to do. And so you have to work with them to make them understand that we really do want them involved. So we had our where to go for information. We had what we wanted to do. We had why we wanted to do it and how we're going to do it. So now we wanted to talk about who was going to be a part of our Patient Family Council. So some of the things that we took into consideration when we were choosing patients was past patients or family members of patients. We looked at regional community members. We don't just take care of patients in Grinnell, we take care of patients in surrounding towns, and we wanted them involved. We wanted a diverse group of age, sex, and backgrounds. We wanted people who weren't afraid to give their opinion, but you also didn't want someone who's going to monopolize a conversation or, get angry and those types of things, somebody that would work with us. And we wanted good storytellers that would tell the experiences that they've been through. Currently, our current members we have a very dynamic 92-year-old retired nurse who was also on our hospital board for a number of years. We have a couple of active volunteers here at the hospital. We have a gentleman who lives in, another gentleman who lives in the senior apartments. There are several senior housing complexes in Grinnell, and we've tried to get representatives of those to sit on our council. This gentleman not only is a voice of the apartment building where he lives, but he also works at our fitness center, works out at our fitness center every morning and goes to coffee at Hy-Vee. So he is out in the people and he hears what's going on and what they're saying about the hospital. We also have a couple of recent retirees that were very active in the business world. We have the swimming coach at Grinnell College who's in his late 30s, and another college employee who's newly married and in her late 20s. So some of the other types of people that we've had over the years, we've had a couple of retired physicians, we've had college students, we've had mothers with school-age children, and we try and look at getting a broad array of different ages and experiences. When we decided when we were going to have it, we tried to find a date and time that would be most convenient for all involved. And so what we came up with was that we would meet every 2 months, and the meetings would be from 5 in the evening till 7 in the evening. And 2 hours may seem like a long time, but we do serve them a meal, and we serve a meal that is also served to our patients, and they have a little survey form that they fill out about the meal and give the nutrition services director a lot of good feedback, and she really appreciates that. And then it seems like that 2 hours just flies by, and we've talked about changing the format and maybe meeting over the noon hour or something, but the current members of the committee really seem to like what we're doing now, so we've stuck with it. Things that we cover at our meeting are, of course, we ask for feedback from them, but we also give them reports on what's going on at Grinnell Regional. We talk about physician recruitment, construction projects, financial challenges that we're having, our patient satisfaction scores. We want them to be as informed as possible so that when they're out in the community, whether they live in senior housing or they're at meetings or their jobs, they can communicate accurate information, be our ambassadors. We also encourage them to bring any rumors or questions that they hear in the community back to us so that we can get the accurate information out there too. Some of the projects that we've worked on, anything that has to do with patient information or information that's going to the patients, we try to take through the patient family care council and get their feedback on, they'll give us feedback on the type of print. If there's too much there, they'll tell us to hone it down, simplify it. The ER project, the remodeling project that we're doing, we set up a mock version of what the ER is going to look like about a year ago with sturdy cardboard, and we took the members of the council out and had them go through it and look at it from a patient view. They were very integral in getting our room service project going. We had one of our members come in on the weekend, and I wrote down departments for her to find, and she went totally by the signs that were up. She wasn't terribly familiar with the hospital, and she gave us feedback on our signage and how well it worked and things like that. Those are the types of things that we've taken to the Patient Family Care Council. Next slide. Some of the keys to the success I think that we've had are to make sure that the council sees itself as a part of the solution and that they're just not bringing us problems and then expecting us to find that they actually help us come up with the solution. It also helps when you're getting started to have a combination of quick fixes instead of long-term projects so they can see success right away and feel that they are a part of making a difference. Make sure that they're meaningful efforts, that they've, and stress their importance to the hospital and how much we appreciate what they do, and celebrate the successes. And the main thing is to stick with it. Therefore, sometimes currently we have 8 members on our council, and I think there was one time last summer people were gone on vacations and that type of thing, and we only had 3 people come. But we still have our meetings, and we still go forward with it, and we've been successful. Our first meeting was held on April 26, 2006. So it's been over 10 years, and that time has just really flown by. And one thing that I have found that works with the Patient Family Council, that if we have a project that I'm getting frustrated, that it's kind of stalled and not moving forward, if I take it to the council and then say, this is what the Patient Family Care Council wants to do, it seems like it moves through the red tape a little faster. That's another big advantage. So our journey is continuing. We've been going for 10 years now, and our goal is to hopefully thrive and continue to grow. We feel like we've only scratched the surface of the possibilities of things we can learn from our council. With all the changes in healthcare today, we don't know what's over the next hill of our journey, but we plan to continue to build what begins in the Patient Family Care Council and then expands out to the patient's bedsides, doctor's offices, and into the community. We want to make sure that patient-centered care is given wherever a person's current or future health needs are being met. So thank you.
Thank you, Janet, very much. We do have one question. How did you establish your PFAC members? Did you have an application? Did you invite members of the public? Did you do a targeted invite?
We invited members to join, the ones that were recommended to us. There were some that I knew. There were some that administration thought would be good. And at first we just interviewed them and asked them if they'd be interested. And then when I have new members recommended to me, I call and when I ask them, I say, just come to a meeting and check us out. And so see if it's something that you want to do. And so far, everybody that's come has decided to continue to be a member. And we've been pleased with everybody that we haven't had the situation, which I hope we never do, where they're not working out and we would have to ask them to leave. But
along those same lines, how long do your members stay on the council? Are there term limits?
We have like 2-year terms, and we ask, our bylaws say that they will not be on longer than 3 terms, but we have a couple that, like I said, the 92-year-old, she enjoys coming so much that she is, I think, going to quit coming like next year, but I just didn't have the heart to tell her, and she still contributes very well to it. So that's my fault, but I haven't really enforced that. I don't tell somebody like that they're not needed anymore, because she is needed.
Who attends from your hospital staff?
Myself and the director of our PR, and someone from administration is usually there, either the vice president or the CEO. We also frequently invite some of our department directors to come and talk about their departments, and we encourage them to come, and some of them will sit in on the meetings too.
Are there any board members on your council?
We don't have any current board members, but we have had 2 that were past board members come.
Great. 2 more questions. Do you share your HCAP data or comments with your PFAC? Yes,
I do. Mm-hmm. Yeah, we look at it in a variety of ways. So sometimes I show them the Press Ganey results. Sometimes we'll go on Hospital Compare and look at how we compare to like the surrounding hospitals that are closest to us. And they find that really interesting. They're very informed on value-based purchasing, and they really ask intelligent questions and make good suggestions.
Great. Comment here. We're just starting to look at this as an option for our facility. One question we have, would you suggest compensating members of this council in some way, or providing incentive for participation, or just on a volunteer basis?
I would hesitate to do that, but you know, maybe in the larger hospitals you might need to do that, but you know, that's never come up. They're not doing it. That's not what's motivating them to be a part of the council. They come because they want to see us, you know, they want to see us succeed as a hospital. They want a, you know, thriving, safe place hospital in the community, and that's enough for our people, and I'm sure there's people wherever you are that would be the same way.
Great. And would you be willing to share your bylaws? Would you be willing to share that on Hinnovation?
Sure.
Or with other people? Okay. And what about patient complaints? Do you share those with your PFAC for problem solving?
Yes, if it's one that I feel that I would get, that I need feedback on, or something that maybe I want to know if they feel like that's a problem, you know, hospital-wide, or that type of thing. I can't think of a particular specific complaint that I've ever taken to them, but you know, I've taken like categories of complaints to them. And one of the things that we struggle with on our patient satisfaction survey is, would you recommend? We'll get high scores on everything, and then our score compared to the surrounding communities isn't as high on the would you recommend. So those types of things. We've talked about what might be causing that and what can we do about it. Whatever we're doing is working because our score is coming up. So
that's fantastic. Well, it doesn't look like any other questions or comments. So Janet, thank you so much for sharing with us. I'm sure we'll have more questions, or I'm sure people will be in touch with you after the event today. It was really, really helpful, and we look forward to hearing more about your success with your PFAC in the future. Okay, thank you. Thank you. All right, so we are going to move on here to our next presenter. Let's slide here. Tom, are you on the line?
Hello, I'm definitely here.
There you are. All right. Can you hear us okay?
Sure can, thank you.
All right, so we'll go ahead and hand it over to you. Stacey?
Okay, great, that is sent. Anything else I can help you with?
Okay, following in our person and family engagement theme, today we're going to hear from Tom Workman. Tom is a principal researcher focusing on health policy and healthcare quality improvement through patient and family engagement at the American Institutes for Research. He is an advisor to AIR's Center for Patient and Consumer Engagement and has worked on a variety of projects related to involving stakeholders in healthcare research, service, and policy decisions. Dr. Workman has more than 15 years of experience in coordinating, facilitating, and evaluating stakeholder engagement in a variety of settings for health policy and program implementation. At AIR, he is involved in multiple projects for the Centers for Medicare and Medicaid Services, the Patient-Centered Outcomes Research Institute, and the Agency for Healthcare Research and Quality. His doctorate in communication studies with an emphasis in health is from the University of Nebraska-Lincoln. And with that, I will turn it over to you, Tom.
Thank you. Good morning, everybody. Delighted to be with you. Go ahead and advance to the next slide and probably on to the one after that. And we can actually dig in and start. Thank you. Everyone, I want to thank you, first of all, for the great work that you've been doing in PFE implementation. It's really been quite exciting, and grateful to see the advances that you've made. And you do have some wonderful heroes in your region who have been doing some great work for a very long time, well before Partnership for Patients, as you just heard from Janet and Grinnell. And so there's certainly plenty of great leadership to follow. I want to talk just for a second about the resources that are available to you, particularly around addressing Metric 4, which is the formation of a Patient and Family Advisory Council. Or whatever name you want to give it. The name is not necessarily important, but the metric really is to have this type of level of engagement, as you saw earlier in the presentation, in the morning actually, that really enables policies and procedures to be addressed on a regular basis across the hospital using patient and family advice, using their experience, using their input. And so the very purpose of this committee, or really this metric, let me start even broader, is to gain that level of input on issues that are broader than any individual patient outcome at the hospital. There are two approaches that you can take to accomplish PFE4, and we really recommend hospitals start with one to get to the yes, and then move towards the more impactful option. So the first option is to put a patient and family advisor directly on your any of your quality committees or any hospital committee, so that that committee can start to develop some patient and family advisor perspective. So that patient and family perspectives and opinions and experiences are integrated within that committee. To say yes to Metric 4, then, all you need to do is have one patient and family member added to any of your hospital committees. We recommend the quality or safety or patient experience committees first and foremost. Especially if you're regional and you're just growing the number of patient and family advisors that you have available to you, we then recommend that you, as you continue to develop those, think about the formation of this larger council that becomes a committee in and of itself. This committee is usually made up of both patient and family advisors, as well as hospital staff and clinicians and administrators. It's important that this committee is not actually just all patients or family members, but is also a combination with patients and family staff addressing patient-related issues, as you just heard explained by Janet. And we've had PFACs that have worked on a wide variety of things, from, as Janet mentioned, any number of the quality and safety issues that you're trying to address, or any number of issues that impact the patient and family experience. And particularly, this is the council that can help address how to best impact patient and family engagement in the other metrics. This is the council that can really help think about, do we have the right checklist at admission so that we're having this conversation, PFE1? Are we having nurse round or shift change in a way that is really meaningful and impactful with the patients? Are they engaging in that conversation, PFE2, et cetera, et cetera. So you can see the importance of this PFAC. To get to that level, and to get to that PFAC, and again, let me just make the point again, you can start to say yes with that first action while you're working towards develop a PFAC. I do recommend that you move towards a PFAC. In other words, don't settle with your yes, because the committee has so many greater benefits for your hospital and really is a gift to your hospital in some amazing ways. To get there, though, our roadmap, and that you heard earlier today that roadmap, the new version of that is available. The new version simply makes things a little bit clearer and simpler for each of you as hospitals to follow and to implement. But the real goal and the real purpose of this roadmap is to lay out a map for you of exactly what sorts of things you can be doing that will lead you successfully to implementation. We have 6 of those. As you can see here on the slide. The first strategy is organizational partnership. Where within the hospital do I need to start build partnerships so that we can establish this kind of committee? In other words, this may be our volunteer services. This may be different units who have different patients that have been involved, perhaps just at the unit level, or that a clinician is very familiar with. By establishing those partnerships and building up, again, this collection of people who show some interest in being engaged in this level at the hospital, we again could start to build the ranks of those who may be interested in participating in that committee. Certainly we'd want, and again, we want buy-in from across all of the organization, from our C-suite down to each unit that's going to be involved. And so that may develop build that kind of buy-in so you have full support in your hospital. Obviously, we need to prepare the patients and family members who are going to be a part of that. And that includes our selection process and thinking about whether we need to interview. Obviously, there are patients who may not be ready to serve in this way, as we've mentioned earlier. For example, there may be patients who are too close to an impactful negative experience and haven't quite worked through all their emotions, aren't able to move from their story to the larger hospital story. And so you may have some selection processes that you put in together, and certainly some preparation processes that you put together. We want to do the same thing with clinicians, staff, and leadership, so they know how to use a committee like this, and they know how to establish those relationships and get the most out of this committee. Sometimes just telling staff what it means when we have patient and family advisors entering the hospital on a regular basis is enough of a change that we want to prepare staff for that, so that they're thinking about these patient advisors differently than they're used to thinking about. The care policy and process redesign means that sometimes we have to change a system in order to make this happen. We have to look back in our other policies and see if there's something within our systems that may be adding to or causing problems. And so we want to address those. Obviously, we want to measure and research and make sure that we see that there's an impact and measure the impact that's happening. Let's look at our quality scores before the PFAC started working on it, and let's look at them afterwards. Let's see if, in fact, we can connect what's being done at our hospital to some actual outcomes that make the most, that matter the most to all of us. And finally, we want to make sure we have transparency and that we're sharing everything we need to share about the hospital to the PFAC so they can make the most of that and they can do the most of that. That includes accountability, of course, not just on the hospital side, but on the committee members' side, the accountability of being sure that they do maintain confidentiality, that they use that information as privileged information and maintain it appropriately. Next slide, please. These 6 strategies are really wonderful approaches that each individually or collectively then lead us down the road to accomplishing our PFAC. And so what order we do these in is something that you can mix and match and play with depending on what your hospital's needs are. You may need to start with those partnerships, or you may already have many of those established, so you can move right to adjusting any systems that you need to make sure these meetings can occur. Again, you may even have to adjust systems if you do plan to provide an honorarium for those folks, or even if you do plan to give them access to certain records, there may be some policy or system adjustments. Get those out of the way first, and then again move towards preparing your staff, preparing your patients, or perhaps even establishing issues around accountability or transparency. Again, thinking about these strategically and which one of these I can take apart at a time is a wonderful way to kind of move forward. Next slide, please. So one way that we're going to suggest that you use these strategies to think about the strategies that will help you then identify a specific tactic. From the tactic, you can find quite a large number of tools that'll help you accomplish. Next slide, let me show you what I mean by this. So for example, when we're thinking about a PFAC, the strategy out of the 6 that we're looking at perhaps is the patient and family preparation. Now specifically, there are a number of tactics, as I've sort of mentioned, that we'd want to take on. One of those, of course, would be some kind of onboarding or orientation training for the new advisors who are going to join the committee. Now, I know that that's the best tactic for me to accomplish family preparation because, again, it's best practice, etc. And so now I got to find a tool. Do I create this orientation and training? Where do I get the materials for that? Well, the answer is that I look for those kinds of tools that are pre-existing, and I'm going to show you we have all of those tools. Around patient and family advisories, we have literally more tools than any other PFE activity in the country, right? Except for perhaps nurse shift change. But really, we have some marvelous tools. In this case, I'm going to refer you to the ARC's Guide to Patient and Family Engagement. This exists on our resource library, which I'll mention in just a second. They have an actual sample orientation manual and PowerPoint that you can take and adapt and use so that you can accomplish the tactic which accomplishes your strategy. The same may be true if you want the strategy of clinician staff preparation. What's my tactic? Well, here I'm going to do information sessions. I'm going to help the hospital, whenever they can, understand and how they work with patient advisors and what that whole concept is, what the benefits are. And now I know that's my tactic to get buy-in from all my clinicians and staff, but I'm not quite sure how I do that. Where do I get the information for that? Again, I'm going to move to a tool and look to see if an existing tool exists, and it certainly does, again, in the ARC Guide to Patient and Family Engagement. In fact, I'm going to recommend this guide because it has a marvelous collection of tools for you. One of the recommendations in ARC's Guide to Patient and Family Engagement is the formation of these committees and the use of patient advisors. And so it has an entire implementation handbook available to you to accomplish all of those things. Next slide. So let's talk about those tools and resources. But I hope you get the larger point before we even talk about these, because what happens is we tend to put this list up and people rush to the tools. Remember that your best strategy, the most efficient way to accomplish your implementation, is to start with a clear identification of the strategies, and then to move to what tactics you want to choose to accomplish those strategies, and then move to your tools. You'll find your search is a whole lot faster and easier. A lot of these are combined, again, in that specific document I told you about, the ARC Guide to Patient and Family Engagement. We also have pre-recorded training webinars on each of the metrics. We have individual metric roadmap packets if you just want to look at metric 4 and the roadmap there. And we certainly have templates and samples and guides for each one of those, as I mentioned. Encourage you to attend our monthly PFE learning events. You'll hear more of those from Compass. And we even have a monthly learning event for our affinity group that helps us address some of our key challenges. With that, I'm excited to see more and more hospitals get the gift of a patient and family advisory council. It is truly a gift. It has truly helped impact a wide range of quality and safety issues for hospitals, and it's probably the best way for us to keep in touch with what is happening from the patient perspective. Stacy?
Thank you, Tom. I really appreciate your presentation. For everybody on the call today, AIR has tons of really great resources like Tom mentioned. We will have those all available on Hinnovation for you to access. And the slides will also be available on Hinnovation as well, so you'll be able to go back and look through the different resources that are available and access those. If your hospital needs maybe some additional coaching or would like to have some more time with Tom or the Compass team, please let us know. We would be happy to set up an individualized coaching session or a meeting with Tom and the AIR team and Compass to help you move along your PFE efforts. So again, Tom, thank you very much. We greatly appreciate all the support that you've given us and our hospitals through HIIN.
You are very welcome, and thank you.
Not a problem, thank you. So with that, we are right at time. I'm gonna just kind of open it up one last time to see if anybody has any questions or comments for any of our presenters or for the Compass HIIN team here at IHC. Doesn't look like it. All right, like I said, all the presentation slides will be available on Hinnovation. The recorded webinar for today will be available on Hinnovation as well as soon as we get it transcribed, and we'll get that posted. It will also be posted on YouTube, so we have that YouTube link for you all to access for future viewing. A huge thank you to all of our presenters for joining us today and all the great information that they've provided, and a huge pat on the back and round of applause for all of our hospitals and the work that you are doing to move along our patient safety efforts with HIIN. So thank you again, everybody, for joining us, and we'll see you all again soon. Thank you.